Would you like to know more about that engine that's in your chest? Stay tuned, and today you'll learn to be a heart mechanic. I believe we can prevent heart attack. We can put in place strategies to reduce risk. We can literally plan to change your future. I call it Healthy Heart Network. Hi, I'm Dr. Warwick Bishop, and welcome back to the Healthy Heart Network. Your heart is probably the best pump you've ever owned. The heart can last for over 100 years without service or maintenance. If it beats at, say, 80 beats per minute, then that is 4,800 times per hour. If we consider that over 24 hours, that's 115,000 times a day. And then if we multiply that over a year, that gives us 42 million beats in the year. Now, if you live to 80 years of age, your heart will have beaten over 3 billion times. The engine block of the heart is a muscle about the size of your fist, weighing 10 ounces or 300 grams. It's a hollow structure and holds about 120 mils or half a cup when it's full. 50 mils after contraction, meaning it pumps about 70 mils each pump. The heart also has valves and it has an electrical system. It importantly also has a fuel system. So how does the heart work and what are the main parts? The heart has an electrical system. It has pistons, the muscle of the heart, and valves and fuel lines. The role of the engine is to pump blood around the body. This is called the circulation. The circulation is really the way the blood moves around the body, and there is a series of one-way valves that allows the heart to come back from the body into the right side of the heart through these main blood vessels into the first chamber on the right-hand side, the second chamber on the right-hand side. The blood then gets pumped to the lungs where there's an exchange of oxygen and carbon dioxide. Red oxygenated blood now comes back to the heart. It gets a small pump, a large pump, and then out through the arteries. The arteries are the blood vessels that pulsate and squirt if they were cut. Well, that's blood flow around the body. So what about the electrical system? Let me show you by doing a drawing. Okay, so if we're going to think about the electrical activity of the heart, we start by understanding there's 4 chambers, 2 chambers on the right-hand side, 2 chambers on the left-hand side. The top and the bottom of the heart are separated by a fibrous ring, and there's a connector, a node that allows conduction of electricity between the top and the bottom. There's an area in the top part of the right side of the heart that literally beats the drum that the rest of the heart marches to. It will release an electrical impulse that will pass through this node and then into special conducting tissue that allows the heart synchronous coordinated contraction. Without this special conducting tissue, the electrical impulse would start just beyond the node and the heart would contract from the top to the bottom, trapping blood inside. Luckily, we've been designed better than that. Now for the blood flow to the heart, the coronary arteries. The coronary arteries arise from the aorta, which is the largest blood vessel in the body and the blood vessel that the heart pumps directly into. There are 2 coronary arteries, named the right and the left. The right coronary artery embraces the corner and curve of the right side of the heart and then goes to the underside of the heart. The left main coronary artery comes off and branches into 2 main arteries called the circumflex and the left anterior descending. The circumflex artery wrapping around the back of the heart, the left anterior descending artery running down the front of the heart nearer the chest wall. These arteries, if we could take them out of the rest of the tissue from the heart, would look like this. And you can see how they sit coming off the aorta and wrapping around the muscle of the heart. They sit on the surface. In total, with the right coronary, the left anterior descending, and the circumflex, they comprise about 35 centimetres of blood vessel. Really not a lot if you think about one blockage leading to a heart attack. It's not a system with much redundancy. In summary, I'd like you to try and understand that there are some real similarities between a car engine and the heart. Firstly, the heart has an electrical system for timing, coordination, acceleration and deceleration. The heart also has pistons and valves, the compression chamber, the muscle, and the valves that allow blood to only go one way. Lastly, the fuel lines or the coronary arteries, which will be our current interest for the rest of this series. So when did you last check the engine in your chest? Stay tuned for our case study, Mary, a grandmother with chest pain. Well, hopefully you've learned a little bit about the structure and function of the heart and understand how it's your engine. Today, the case is Mary, and I'm going to tell you a little bit about her. Mary is a 65-year-old grandmother. When I first met her, she was wearing a pink jumpsuit and had her hair in a beautiful perm. She was proud because she'd just had her first grandchild. Mary admitted that she'd smoked over the years and in fact had some narrowing in her leg arteries from the smoking. She'd given that up a number of years ago. I'd seen her over a period of time and perhaps 18 months earlier had organised for a treadmill test because she was describing some chest discomfort and shortness of breath on exertion. That treadmill test didn't show any major problems at all, but nonetheless I put her on some medication which were anti-anginal, anti-chest pain, and these worked very well. She was of course on a bit of aspirin and a cholesterol lowering agent, and when she came back to see me, she had recurrence of pain in the chest. Given that our treadmill test some months earlier had not shown a major problem, I thought a CT of her arteries may be a really good way to be really clear about what we're dealing with. And so we organised some imaging, and this is what we saw. The 3D model of what our arteries look like. I'm going to bring your attention to the right coronary artery, and you can see, just in this reconstruct, some irregularities. But if we look over here, there's a real suspicion that this bit of artery is nowhere near as healthy as this bit, nor this bit here. In the setting of symptoms with this abnormality in a lady who was no longer controlled on medication, we went and did further testing, and that was an invasive coronary angiogram, so we could get the clearest pictures of exactly what was going on in the inside or the lumen of her artery. This looks very much like what we saw on the CT and confirmed that there was a problem there. In fact, we made arrangements for a stent to be deployed to open that artery up. This resolved and improved Mary's symptoms. She's now playing with her grandchild. In fact, she's had many more and is feeling well. Stay tuned. Our next section is patient questions. Welcome back. We're now in the patient question and answer section, and today's question is, what is angina? I bet you've heard the term, but you've never quite been sure what it means. The term angina comes from the Greek or Latin. To be honest, I can't remember which, but the term relates to the sense of strangulation. It's the term that fits perfectly for people who have problems with their hearts. They feel this sense of restriction, this choking, this strangulation. So angina can be characterised by the things that we are fully aware of. Things like chest pain, pain into the arm. I've seen people with pain in the jaw. I even know of a patient who had 3 sets of dentures changed because they thought that the dentures were causing them discomfort. It wasn't until they had correction of their underlying coronary disease that their dentures worked properly. Some patients have pain from their heart in their back and shoulders. Some people get indigestion or confuse indigestion with heart pain. Occasionally, people don't have any pain at all. And sometimes shortness of breath on exertion can be the only symptom of angina that someone comes and presents with. So what's going on in terms of lack of blood supply, and what does angina really mean? Well, let's look at a diagram. This is a non-flow limiting lesion, a plaque that's not limiting blood flow to the heart muscle. And here's a flow-limiting lesion, one that allows enough blood through that at rest the heart is fine. There is no symptom, there is no chest pain or discomfort. But as the patient exercises or moves around, then the demand for oxygen and nutrients is increased. And this narrowing then prevents an increase in blood flow that's required to sustain that activity. So angina is the lack of blood flow to the muscle that gives rise to pain. Now, we've possibly all experienced a form of angina ourselves, because angina is simply a discomfort from cramping or lack of blood flow. You may have seen sports people at the end of a competition fall to the ground with cramp in their leg. Your heart is suffering exactly the same. The difference between angina and a heart attack is really important to understand as well, and let me dwell on that just for a moment. In a heart attack, there can be a sudden rupture of a plaque that can lead to sudden complete closure of the artery, and that can occur on non-flow limiting or flow limiting plaque. It's in the situation of non-flow limiting plaque where there's been no warning whatsoever. Angina can be similar, but the difference with angina is it does not lead to complete blockage of the artery. There are two types of angina, and I'll separate those out because their behaviour and their management is very different. The first type of angina I'll talk about is the sort my grandfather used to have. It's called stable angina. That's the situation where over time cholesterol is built up to such an extent that not enough blood can get through when the workload of the heart is increased and more nutrients are needed. Normally you need a narrowing of at least 70% of the lumen for that to occur. It's a stable phenomena in that my grandpa, over the course of months, might have been able to walk half a mile, get chest pain, stop, have a rest, recover, walk half a mile, have chest pain, stop, have a rest, recover, and do that day after day, week after week, for months at a time, in a stable, predictable way. Angina can also be unstable, and it's really important you understand the difference. This is a situation where either a non-flow limiting plaque that ruptures or a flow limiting plaque that ruptures, like this, gives rise to a plaque that almost occludes the artery. It doesn't completely close it, but it is very close. This is incredibly close to progressing to a heart attack. And this is a situation, particularly for people who have had no symptoms prior, where they can be well 1 minute and have a heart attack the next. This is why chest pain is so important, and it's so important that I'll revisit angina in a later episode. But take away stable versus unstable, and take away that unstable is a real red flag for further evaluation. Well, that concludes this question and answer session. Thank you for joining me. I hope you feel better educated and informed about your heart, and I'm sure you're looking forward to the next heart-pounding episode. Until next time, please don't die from a heart attack. Want to know more? Grab a copy of my #1 best-selling book, Know Your Real Risk of Heart Attack. It's available as a hardcover or a paperback and an audio from Amazon or wherever good books are sold.